invite me, so I'll
Thank you,
present my
James.
data.
Today, I'd like to introduce a global clinical trial for childhood liver tumors named FIT. There is no conflict of interest to be disclosed. In childhood liver tumors, 90% are hepatoblastoma. A cisplatin is used as a first-line chemotherapy. However, the incidence is very rare. To improve outcome and reduce toxicity, global study is needed. In the 20th century, the outcome of hepatoblastoma was poor, and metastatic cases were remarkably poor. To improve their outcomes, we set up JPLT, Japanese Study Group for Pediatric Liver Tumors at 1989. This graph shows the annual registered cases in JPLT. The registered cases gradually increased. We conducted several clinical trials like this. To evaluate the efficacy of cisplatin and pilarisin, so-called SHITA, JPLT-1 protocol was started at 1989. Then JPLT-2 protocol was launched out on 1999 to evaluate the cure rates of risk-stratified hepatoblastoma using pretext system. The data of these trials were already published. At the same era, Cypher Group has performed clinical trials consisting of mainly Brado regimen. Brado is involving cisplatin and doxorubicin. Recently, they revealed cisplatin monotherapy was tried in standard-risk hepatoblastoma and high-dose chemotherapy. Cisplatin is effective high-risk hepatoblastoma patients. In the North American, they use C5V regimen, and recently AHEP study added doxorubicin in advanced cases, which is so-called C5VD. To establish global clinical trial over the world, we had the first international conference Gdansk at 2007. In 2011, we conducted MOU of Children Hepatic Tumor Consortium, so-called CHIC, to produce international database in Los Angeles. As a result, we made a new database consisting of these 8 trials and performed multivariate analysis using total 1,605 cases. After these analyses, we made new international risk stratification, which was published in Lancet Oncology. This divided hepatoblastoma into 4 groups: very low, low, intermediate, and high risk. Based on this risk stratification, we propose a FIT trial as an international trial for pediatric hepatic tumor, including hepatocellular carcinoma. The aim of this trial are reduction of toxicity in good prognosis tumors and improved outcome for poor prognosis tumors, like these group D. Hepatoblastoma started into 4 groups according to this stratification, and hepatocellular carcinoma into 2 cohorts: rejected and unresectable. This shows the trial entry induction criteria. Histology confirmation of hepatoblastoma or HCC is needed, expected, in emergency situations, and trial duration is 4 years of recruitment, and follow-up assessment is a minimum 2 years. This is a schema of very low-risk hepatoblastoma. After complete rejection at diagnosis, no chemotherapy is administered in the cases with well-differentiated fetal histology, and two courses cisplatin monotherapy are done in other cases. In Group B, for low-risk hepatoblastoma, after two courses of cisplatin monotherapy, the resectable cases will be randomized into 2 or 4 courses after resection to reduce the chemotherapy. For intermediate-risk patients, we randomize into 2 arms, C5VD and cisplatin monotherapy, for evaluating whether cisplatin monotherapy is effective or not in this risk group. In high-risk patients with distant metastasis, cycle-4 therapy is used as an induction chemotherapy, and then the cases were divided in two groups. Group 1, the cases whose metastases were cleared by chemotherapy were treated by the usual consolidation therapy. The cases whose metastases remain after induction therapy were randomized into 2 chemotherapy courses investigated as a new therapy. This shows the regimen for hepatocellular carcinoma. In the rejected cases, those arising in the basic disease were followed up, and the de novo cases were administered with Prado. In unresectable or metastasis hepatocellular carcinoma cases were randomized into Prado with sulfanium or Prado and Gemox with sulfide. This slide shows the primary and secondary objectives: to evaluate the reduced therapy in localized cases and to determine the aggressive therapy in advanced hepatoblastoma and hepatocellular carcinoma. And we collected samples for biological studies. This slide shows the sample size of this study. Total expected cases are about 1,200, and 20% of them are expected in JCCG study. In this study, we introduced real-time center review system for pathology and radiology at diagnosis. In very low-risk cases as Group A, histological finding of rejected tumors decided whether the following chemotherapy is required or not. In hepatocellular carcinoma cases, histological evaluation is needed before enrollment, and radiological review should be done before grouping, especially in pretext 2 or 3 cases. Radiological findings for annotated factors including portal and hepatic vein or tumor rupture are important to divide it into Group B and C. In addition, center review should be done before resection or transplantation by radiologists and surgeon. This slide shows the schema of imaging center review system in our JCCC. The diagram data including CT and MRI data sent by a Dropbox or FedEx, like this, from each institution, and then uploaded into cloud as anonymous data. And then radiologist diagnose this imaging at own computer. The radiologist diagnose this imaging at own computer. The radiologist diagnose this imaging at own computer. And then radiologist diagnose this imaging at own computer. And then radiologist diagnose this imaging at own computer. And then radiologist diagnose this imaging at own computer. And then radiologist diagnose this imaging at own computer. And then radiologist diagnose this imaging at own computer. And then radiologist diagnose this imaging at own computer. And then radiologist diagnose this imaging at own computer. And then radiologist diagnose this imaging at own computer. And then radiologist diagnose this imaging at own computer. And then radiologist diagnose this imaging at own computer. And then radiologist diagnose this imaging at own computer. And then radiologist diagnose this imaging at own computer. And then radiologist diagnose this imaging at own computer. And then radiologist diagnose this imaging at own computer. And then radiologist diagnose this imaging at own com in each institution as a real-time review. In addition, using the imaging during treatment, center review was also evaluated the therapy effect and rejectability. In this system, all investigators, including oncologists, surgeons, pathologists, can be acceptable these storage data for decision. The shared data will be uploaded from each country using electronic CRL, and then the data will be merged with COG data like this. The data will be able to be analyzed in each consortium as well as merged data like this. We have a surgical guideline in this protocol. For example, we permitted resection at diagnosis in the patient with a tumor where there is a more than 1 centimeter radiographic safety margin from middle hepatic vein, and we resection and transplantation guideline in this trial. This is a schema of data management. This global study will be performed as 3 individual consortia and merged in these data into the generic system. Asian group included Guangzhou, Hong Kong, Singapore just now participated in our JCCG consortium. We were extended this clinical trial all around Asia. Welcome to join this trial. If you want to join us, please contact this URL. These are my collaborators. They are council member, radiologists, surgical plantation committee, and pathological committee and statisticians. They are Ganzu, Professor Liu is the PI, Hong Kong is Aaron, Singapore, Sosui and Amos is the PI of these institutions. Thank you very much.